The strategy for these PFS meetings is that we want, if possible, to bring in the people who are actually doing the work to study these different treatments. And so recently, Dr. Voorhees has led a very important study where he's been looking at the use of 4 drugs. And so one of the big questions right now is, should we be using 3 drugs versus 4 drugs, a triplet versus a quadruplet? And so it's very helpful to have someone like Peter, who is not only the director of the cancer center, good luck with that. Yeah, it's so tough these days in medical administration to have these responsibilities, which come as you move forward in your career. But the important thing is that he's able to continue to do his myeloma work. And so look forward to your presentation today, Peter.
Thank you.
So please welcome Peter.
All right. Thank you very much, Dr. Dury, and thanks to the IMF for giving me the opportunity to talk to you today. I'm going to be talking to you about initial treatment of multiple myeloma. All right. So we're going to talk about the drugs that we use to treat newly diagnosed myeloma, how we choose the best therapy for our patients with myeloma. We'll talk about this evolving role of transplant for patients with newly diagnosed myeloma. And then we'll go on and talk about treatment strategies for patients who cannot or do not want an upfront transplant. Those treatments for patients who can and want an upfront transplant. We'll talk a little bit about maintenance therapy, and then we'll wrap things up. So, as you all know, treatment of multiple myeloma is a marathon. It's not a sprint. And once you start therapy, this is a long-term process. So on the top of the slide here, you can see for those patients that are transplant candidates, typically we'll apply what's called induction chemotherapy with 3 or 4 drugs with the goal of debulking the disease and getting the patient into a good remission. And then we'll proceed with the transplant. We'll talk more about that to drive the remission even deeper. After that, there may or may not be a brief course of consolidation therapy, followed by maintenance therapy, which can be given for an extended period of time. For the non-transplant patients, it's the very same thing without the transplant. So let's talk about the drugs. So there's really 5 core pillars of myeloma therapeutics. There's the immunomodulatory drugs, and in the frontline setting, Revlimid is the one that we typically use. These are called immunomodulatory drugs because not only do they have activity directly against the multiple myeloma, but they augment certain branches of the immune system, such as T cells and what are called natural killer cells. So when we use these drugs as maintenance therapy, in part we think that these work by augmenting immunity to the multiple myeloma. There's the proteasome inhibitors. What's a proteasome? A proteasome is this complex inside each and every one of your cells that basically functions as the protein toilet of the cell. So as proteins are misfolded, mutated, etc., they are funneled through this proteasome. And multiple myeloma cells, like plasma cells, are professional antibody-producing cells, and they're very susceptible to the toilet being plugged up. So they don't like it when their proteasomes are inhibited. We have several different drugs. In the frontline setting, Velcade and Kyprolis are the 2 proteasome inhibitors that we tend to use. There's the CD38 antibodies, and that includes Darzalex as well as Sarclisa. There are the alkylating agents, cyclophosphamide or Cytoxan, and then melphalan, which is typically given in high-dose form in the setting of transplant, which we'll talk about. And then there's the steroids, which you either love or you hate, and that's typically dexamethasone and in some instances prednisone. So how do we choose therapy for a newly diagnosed myeloma patient? First and foremost, there's patient preference. This is a shared decision-making process in this country, and this is why these seminars are so critical. You need to empower yourself with knowledge so you can participate in that shared decision-making process with your doctor. The decision to do an upfront transplant or not, that's important. What are the other medical conditions that could potentially affect the side effects of particular drug classes. If a patient has diabetes and painful neuropathy related to that, you're probably going to want to stay away from Velcade because we know that causes neuropathy. If you have significant heart disease, let's say you had a heart attack a couple years ago and the pump doesn't squeeze as well as it used to, you may be a bit cautious about Kyprolis in that situation. If you have bad kidney disease, you have to be very careful about how you dose Revlimid. Do you have standard risk or high risk multiple myeloma? And we've talked about how we define that. And there's logistical factors that have to be considered as well, including how far away are you from the infusion center? Are you going to be able to get to the infusion center 3 times every 4 weeks for a Kyprolis-based therapy, for example? So one of the things that I want to point out is that it really helps to put your best foot forward. There's this concept that we talk about in the myeloma community called attrition. So most people, when they relapse, they're going to be able to get a new regimen to get their disease back under control. But we do lose some patients with each relapse. Now, these data here that I'm showing you, I think, are flawed and exaggerated. I think insurance claims databases can only get you so far. But the point is that there is some attrition that occurs with each subsequent relapse. So putting your best foot forward, giving you the best chance of the longest remission is very important. So let's talk about transplant. So what is it? It's not really a transplant. You're not getting anything from a donor, right? It's just a clever way of allowing us to treat your myeloma with very high doses of a chemotherapy drug called melphalan. We've been using melphalan for over 50 years to treat multiple myeloma, and it's very good at killing myeloma cells. It's very good at killing myeloma cells at high doses. The problem is that it's very good at killing stem cells at high doses as well. So how do we get around that issue? So the way that we do that is after we've controlled the disease with several cycles of induction therapy, we collect stem cells from the patient and we store those away to be used. Patient comes in, they receive a high dose of melphalan chemotherapy to drive their remission even deeper, and as that melphalan clears their system, the stem cells that we previously stored are infused back into the patient. So those cells that we collected were never exposed to the high-dose melphalan, and that's what allows your bone marrow to regenerate afterwards. So a lot of people like to call this high-dose chemotherapy with stem cell rescue, because it's really not a transplant. So we can transplant a lot of people. We can transplant older patients, as it turns out. This is a CIBMTR analysis of close to 16,000 patients. And what you can see here is that the mortality, the non-myeloma mortality, is very low, whether you're 40 to 49 years of age or whether you're 70 years of age or older. That said, there was a very small number of people that were 70 years of age or older in this data set, suggesting that we're very careful about those patients that we select in their 70s for high-dose chemotherapy. So take this with a grain of salt. We can transplant patients who have abnormal kidney function. So again, this is a CIBMTR analysis of close to 1,500 patients. Those who had normal kidney function, moderately impaired kidney function, or severely impaired kidney function. And on the right-hand side here, you can see overall survival at the top and what we call progression-free survival at the bottom. And you can see that the lines for those with normal kidney function, moderately impaired kidney function, or severely impaired kidney function are superimposable. So survival, progression-free survival are the same with transplant regardless of level of kidney impairment. That said, again, very few patients with abnormal kidney function in this data set, suggesting that we're being very careful about who we select in that particular circumstance. Dr. Dury told us about the determination study. This is the phase 3 study that looked at upfront versus deferred transplant in newly diagnosed multiple myeloma. He showed us that for those patients that got upfront transplant, they stayed in remission longer, okay? That said, when you look on the right-hand side of the slide, overall survival was the same, whether you got an upfront transplant or a deferred transplant. Now, if you're a transplanter, you view this as a positive study. You know, we transplant patients, they stay in remission longer. If you're a transplant nihilist, you say, we don't need to be transplanting everybody anymore because the survival's the same whether we do it up front or whether we save it for later. This is where that shared decision-making process has to come into play. It remains a very important standard of care for multiple myeloma. It does give you the best odds of the longest remission up front, but it is a nuanced discussion. We know that quality of life is impacted by transplant. This is quality of life data from the determination trial, and these circles here represent the transplant point, and the red line are those patients that got transplanted. And what you can see here is that their quality of life scores, physical functioning, etc., get worse in the transplant period. But I also want to point out that those lines go right back up to the non-transplant lines as maintenance is getting ready to be started. So yes, transplant is very hard. I'm not going to lie to you, but people recover from transplant, and in the long term, they do just as well as those who did not get an upfront transplant. I think for those that have high-risk chromosomal features, I think the decision to do transplant upfront is particularly important, and we more strongly advocate for that upfront transplant in that particular circumstance. So on the left-hand side of the slide, a very clear improvement in being in remission and being alive for those that got the upfront transplant. On the right-hand side is an overall survival curve showing a trend towards improved survival when the transplant's done upfront for that group of patients. So let's talk about treatment for those who are not eligible for a transplant or for those who do not want a transplant. And Revlimid and dexamethasone represent the core. And why do they represent the core? So there's a number of studies suggesting this, but this was the first trial which looked at Revlimid and dexamethasone, so a 2-drug regimen versus an old school 3-drug regimen of melphalan, prednisone, and thalidomide. And to make a long story short, patients remained in remission longer when they got the 2-drug regimen here, Revlimid and dexamethasone. I also want to point out that Revlimid and dexamethasone was looked at continuously, so as long as the patient was tolerating it and their disease was under control, they stayed on it indefinitely, or they just got it for 18 cycles, or what's depicted here is RD18. And you can see at the 1.5-year mark, that's where those curves start to spread out. So what that tells us is that Revlimid and dexamethasone is an active therapy, but to Dr. Dury's point earlier, it's a therapy that performs best when it's applied for a longer period of time, provided the patient is able to tolerate it. Dr. Dury also told you about his SWOG S077 trial. So we obviously want to do better than Revlimid and dexamethasone alone. And what he was able to show is that when you add Velcade to Revlimid and dexamethasone for those patients that are not undergoing an upfront transplant, that not only did they stay in remission longer, but that they were living longer. So survival was improved by adding Velcade into the regimen. And the Velcade was only given for the first 24 weeks of therapy, so it wasn't applied long-term. With just Velcade in that first 24 weeks, you improve survival of myeloma patients. And this has become a very important standard of care as a result. One of the problems that we have with Velcade is the neuropathy, and when we give it twice weekly, it can be quite severe. And in this study, the rates of more severe neurologic side effects was a third. So there's this RVD light regimen that we talk about, and this is single-arm phase 2 data from the Massachusetts General Hospital group and Betsy O'Donnell. They tweaked Dr. Dury's RVD, giving the Velcade weekly, for example. And to make a long story short, responses were very similar. Progression-free and overall survival looked fairly similar, although with not as much follow-up, and the grade 3 neuropathy rate dropped to 2%. So you can tweak these regimens to make them more tolerable for our patients. So let's talk about the MAIA trial. So daratumumab, or Darzalex, is an antibody therapy directed against a protein called CD38. CD38 is a protein that sits on the surface of myeloma cells. So when we give Darzalex or Sarclisa, either as an injection under the skin or intravenous infusion, that antibody will attach to the surface of your myeloma cells and target them for destruction by the immune system. So the MAIA study was a randomized trial to see if adding Darzalex to Revlimid and dexamethasone for those patients not undergoing an initial transplant would improve outcomes. And the only thing I want to point out on this very busy slide is that this was an older group of patients treated with this particular regimen. So only 1% of the patients in this study was less than 65 years of age, and over 40% of the patients were over 75 years of age. So this was an older group of patients. And what you can see here on this slide is that not only on the upper right are we improving the time in remission, but we're also improving overall survival. And this progression-free survival that we're seeing here, you're going 5 years out, and we're still above 50% of patients in remission. I mean, that's the longest progression-free survival that's ever been reported in a newly diagnosed study for transplant-ineligible patients. And those overall survival outcomes are nothing like we've ever seen before. So this is really strong data, and you're going to see more and more patients with newly diagnosed myeloma getting this Darzalex Revlimid cocktail. Now, if you can't beat them, join them, right? So the question is, can we do even better? So why don't we bring all of these drugs together? So Cepheus is a study, a phase 3 international study that's looking at what happens for those patients that are not undergoing transplant when we add Darzalex to Dr. Dury's VRD backbone. So this is a study that has fully enrolled, and we hope to see these results at some point in the near future. Sarclisa, which is another CD38 antibody, they're conducting a similar study called the IMROZ trial, looking at the VRD backbone with or without the CD38 antibody Sarclisa. So let's talk about transplant-eligible therapy. So the first study that showed that this proteasome inhibitor, immunomodulatory drug, dexamethasone triplet was the right thing to do for transplant-eligible patients was this Jemima trial. And this is an older study where they looked at the addition of Velcade to thalidomide and dexamethasone for those patients undergoing stem cell transplant. They got several cycles of induction therapy with 2 or 3 drugs. They got 2 transplants, tandem transplant. They got a couple of cycles of consolidation therapy and no maintenance treatment. And to make a long story short, the addition of Velcade, again, not only improves progression-free survival, but improves overall survival in the long run. So patients are living longer when they had the Velcade added to their thalidomide and dexamethasone, and this is in the transplant patient population. And I want to report, that these outcomes, these survival outcomes, are absolutely phenomenal, and that's without maintenance therapy. So Cassiopeia was a phase 3 study that took this one step further. So Velcade, thalidomide, and dexamethasone are very active. What if we add the CD38 antibody Darzalex to that? Can we make things even better? So this was an interesting study that again looked at the Velcade, thalidomide, dex with or without Darzalex in the setting of a single transplant. But interestingly, they had a second randomization later to either no maintenance therapy or Darzalex maintenance therapy for 2 years. And again, you see this notable improvement in progression-free survival, so more people living, with their disease under control with the 4-drug regimen compared to the 3-drug regimen. And although it's too soon to make any definitive comments about overall survival, there's this trend that looks actually quite good in favor of the 4 drugs versus the 3 drugs. So in the Alliance Cooperative Group here in the United States, we performed the Griffin trial, which was a bit different than Cassiopeia. We don't like using thalidomide in the United States much. It causes a fair amount of neuropathy as does Velcade. You put them together, the neuropathy can really be quite challenging. So we wanted to look at Dr. Dury's VRD backbone and see whether the addition of Darzalex to that for those patients undergoing upfront transplant could improve patient outcomes. And we did not have a second randomization at the maintenance stage. If you were on the Darzalex arm, you got Darzalex and Revlimid for 2 years, and then you continued your Revlimid thereafter. If you were in the standard of care arm, you got Revlimid. These are the baseline characteristics of the patients, and this is the most important part of it. So on the left here, again, we have progression-free survival. So when that line stays up high, those people are alive and their disease is controlled and it's not progressing, right? And when you look 4 years out, for those patients that got the 4-drug induction therapy, the Revlimid Darzalex maintenance for 2 years, followed by the Revlimid, the 4-year progression-free survival is 87%. That's the highest progression-free survival that's ever been reported in a randomized study in multiple myeloma. When you look at those with standard risk disease, that progression-free survival at 4 years goes up to 92-93%. So patients doing a lot better these days with these improvements. Now that said, as you can see on the right-hand side of the slide, overall survival is exactly the same. You have the ability to get Darzalex and Sarclisa at the time of relapse, and we'll be talking about that in a short bit here. So, showing overall survival in these newly diagnosed studies has become incredibly challenging, and that's a good thing for patients. And it's become incredibly challenging because patients are doing so well that we have to follow them in a clinical trial for years and years and years before we can see any potential differences. We also looked at patient-reported outcomes. So great, we're controlling the disease better, patients are staying in remission longer, but we're adding drug to the regimen. So adding drug means more side effects, right? So we looked at patient-reported outcomes and quality of life metrics, and I've just shown a couple of examples on this slide. So on the left-hand side of the slide, you see pain symptoms, and when that line drops, that means there's less pain, okay? And what you can see is, for both groups, the 3 drugs and the 4 drugs, green and blue lines respectively, pain is improving over time. And that makes sense, right? You've got pain because of your multiple myeloma. The disease comes under control and you're going to have less pain, right? But you can see that there's this trend towards improved pain scores for those that got the 4-drug cocktail versus the 3-drug cocktail. You would think that we would make fatigue worse by adding drug, and that in fact is not the case. People probably had a fair amount of fatigue because of their active myeloma at initial diagnosis, and that fatigue actually got better over time. It didn't get worse, and it favored the 4 drugs versus the 3 drugs. So the nice thing about these CD30/80 antibodies like Darzalex and Sarclisa is that their side effect profiles are reasonably good in the grand scheme of things, and we can add them, to backbone therapies and get away with it from a side effect perspective for most patients. So let's just talk briefly about maintenance therapy. There's a number of studies that have been done, for patients who've undergone an initial transplant where they were assigned to no maintenance therapy versus Revlimid maintenance therapy. Dr. Dury alluded to the differences in outcomes for those in the IFM 2009 trial and the determination trial, where Revlimid was applied for 1 year versus indefinitely. The CALGB also did a study looking at Revlimid continuously versus no maintenance therapy. The MRC in the United Kingdom also did the same. And to make a long story short, overall survival was improved with application of Revlimid maintenance therapy as long as the patient was tolerating it and as long as it was keeping the disease under control. There are studies looking to see what the optimal duration of treatment is. So the endurance trial is looking at 3 years of maintenance therapy versus indefinite maintenance therapy. The SWOG cooperative group is looking at MRD, minimal residual disease testing, after 2 years of maintenance therapy. And if you're MRD negative, you're either assigned to stopping your maintenance or continuing your maintenance. So can we use MRD testing as a way of making decisions about stopping a maintenance therapy? And then lastly, I want to just briefly talk about the fact, that there are going to be new therapies that are going to be introduced into the frontline paradigm. We are doing so much better than we did before, but we could continue to do better. So one of my slides I was going to show was what's called the CARTITUDE-6 trial. So what is that? That is a study that's taking the Darzalex VRD backbone for transplant-eligible patients. Patients are getting treated with several cycles, and then they're randomized to a transplant, or they're randomized to Carvykti CAR T-cell therapy. So we're going to see, and we'll hear more about CAR T-cell therapy from Dr. Munshi, but we're going to see if a CAR T-cell product can do better than a transplant for those patients. You'll hear about bispecific antibodies later. You're going to hear about something called teclistamab or Tecvayli, and there is a study that's building on the Maya trial that I told you about that's looking at Darzalex, Revlimid, and dexamethasone versus Darzalex, Revlimid, and Tecvayli for newly diagnosed myeloma patients not undergoing a transplant. And we're going to look to see if we can improve outcomes even further for that group of patients. So with that, I think I'll go ahead and wrap up, and then I guess we can take some questions. Thank you.
Hi, my name is Louis. I'm from Pembroke Pines, Florida. My question was about the Kappa-Lambda ratio.
Okay.
For example, you can have a Kappa-Lambda numbers like 59 and 57, which is a ratio of 1.03. Suppose a patient has ratios that kind of stay like that for a long time, but both the kappa and the lambda are elevated.
Yeah.
When do you become concerned about the risk of amyloidosis?
Yeah, so there are a few aspects to that. Maybe you want to go first on that.
So there's a couple of explanations for why both the kappa and the lambda light chains may be elevated, yet the ratio remains within a reasonable range. So one would be abnormal kidney function. So if your kidney function is not normal, the kidneys actually metabolize these light chains, and so if the kidneys are not working well, they're not metabolizing them appropriately, and the baseline levels of both of those will go up. So, and there's some subtle changes that can occur to the ratio when that happens, and so we have to be thinking about that when we're interpreting the results of the testing. Anything that causes inflammation can cause those levels to rise. And it's interesting, and I don't know if Dr. Dury's had a similar experience, but there's some patients who are on Revlimid maintenance therapy where they're both just elevated a little bit, and the ratio is completely normal. That's not of concern. That is not an indicator of progression. You really have to look at the affected light chain. So if you have a kappa-expressing myeloma, whether it's IgG kappa or free kappa, you need to see that kappa light chain rising disproportionately to the lambda to be concerned that progression is occurring. There have to be very specific physicochemical features to the light chain in order for it to cause amyloidosis. But if the myeloma is in a complete remission and those light chains that we're seeing on the testing are not derived from the multiple myeloma, you really shouldn't have to worry about amyloidosis in that situation.
Right, right. The other thing that can happen is that if it's a kappa myeloma, the kappa can be normal, but then sometimes when you're on maintenance, the lambda will actually drop. And so then it makes the ratio high. So you have a high ratio, but it's because the lambda is low, which seems to be impacted by the treatment. And so you really need to talk to your doctor about that. But in this low range where you're seeing these, what we call fluctuations, where they're maybe going up and down a little bit, you just need to observe and really not jump in too quickly, because they will fluctuate up and down a little bit. They can sometimes be affected by other medications that you're taking where the light chains are not getting kicked out through the kidney as fast. And so you just need to be a little cautious about potential up and down levels, especially at the lower levels.
And I just wanted to add, looking at the numbers over time. And for those of you that don't know, amyloidosis is a misfolding of the proteins that latches onto tissues like heart and kidney. And so I routinely check a 24-hour urine. We look for extra good protein called albumin. That might be a sign of kidney involvement. If you're having new heart issues, because people are living longer and we might not have seen an amyloidosis diagnosis when you had the myeloma. So just discussing symptoms with your doctor, and then we can do the appropriate evaluation.
Right. All right, so hopefully that's helpful. Number
Hi,
2, okay, go ahead.
Hi, I'm Sergio from Miami. I have a question about Revlimid because I see sometimes you take it every day. Sometimes they tell you to take it 21 days, then stop for 7 days. So what should we ask for, especially if it's maintenance that you have to take it all the time? I had to have a surgery, so they told me, don't worry, stop it for 10 days, then you take it back. So
Yep.
what's going on there?
So that's a great that's a great question. So in the CLGB study that looked at Revlimid maintenance versus no maintenance therapy, they gave the Revlimid continuously with no breaks. And again, we saw an improvement in progression-free and overall survival. The MRC, or Medical Research Council study that was done in the United Kingdom, did the very same thing, but they used 3 weeks out of 4 dosing, and the results are virtually superimposable. My view is that getting that 1 week break from Revlimid therapy is advantageous from a side effect perspective. And I mean, there may be some differences from one myeloma physician to another, but I typically do not use continuous maintenance therapy.
Right, right. I think that especially the benefit is similar, but I think in terms of the side effects, particularly the white blood cell count, I think the continuous Revlimid can really be more likely to produce a drop in blood counts. And so in the SWOG trial, for example, we had 3 weeks on and that 1 week rest period, which I think is very important. And then sometimes over time, if you're on Revlimid for years, which some patients are in the room here, you can go to 2 weeks on and 2 weeks off is another way of doing it. That rest period can be quite important to allow your bone marrow to recover, but also to allow you to stay on the maintenance.
Yeah. The challenge is that the FDA has approved Revlimid maintenance therapy as continuous dosing. So some of the clinical trials that are being done to build on Revlimid maintenance therapy have been kind of forced into the situation where they have to use continuous dosing. So that SWOG study that I was telling you about, where patients can potentially come off of their maintenance therapy after 2 years if they're minimal residual disease negative, that's a study looking at Revlimid versus Darzalex and Revlimid as maintenance therapy, but the Revlimid is continuous because of the nature in which the FDA approved the maintenance.
And there's different doses according to if you had a transplant or not, and depending on if you're a study or not. So talking about side effects, like Dr. Dury said, we have people on 5 milligrams or 10 milligrams, and so we take all that into consideration. So the dose that works for you is the dose you should be on.
Yeah.
So as a patient,
Right.
I understand my doctor has to put me on Revlimid 10 milligrams in my case every day, like forever, but I can choose to take it 3 weeks and stop 1 week.
I think if you're having side effects, particularly in the low white blood cell count that Dr. Dury was alluding to, it's definitely worth a discussion. I mean, I think that they're both very effective choices, and it's really just a matter, again, of this whole shared decision-making process with your doctor.
Yeah.
Yeah.
All right. At the back, it looks like.
Good morning. Luis Perez from Boca. I have a couple of questions related to the Griffin trial because that's very relevant. That's my situation. I just went through the RVDD regimen. Unfortunately, I had a oncologist or someone recommend to my oncologist to go through 8 rounds of this before they collected my stem cells.
Yeah.
And I had 1 round in the hospital of something else where my kidneys weren't doing well. I'm worried about my stem cells being damaged. And I'm wondering if it makes sense to go to transplant knowing that there's a potential that my stem cells were damaged because of the extra rounds.
Right.
Yeah.
So, yeah, go ahead, yeah.
So both in the Cassiopeia trial, which was Darzalex with Velcade, thalidomide, and dexamethasone, and then our Griffin trial, which was Darzalex with Revlimid, Velcade, and dexamethasone, there was an impact on stem cell mobilization and collection when Darzalex was added to thalidomide or Revlimid, and it's that interaction that we think is important. The CD38 antibody, we don't think that that's actually causing stem cell damage per se. It is creating challenges with collection, and we have been strongly advocating that for those patients that go on 4-drug therapy who are considering transplant, whether it's upfront or whether it's for a relapse, they really should be collected as quickly as possible in the process, because there can be challenges with collection, down the road. That doesn't mean that they're damaged. They're perfectly healthy, functional stem cells. It just makes it logistically harder to do.
Okay, so
Right,
that's,
but in terms of being worried about it, I mean, to do the transplant, we do have cutoffs in terms of the number of stem cells. So we're not going to do a transplant if we don't have enough stem cells to be able to give the recovery, right?
Yeah, no, that's exactly right. And if for whatever reason you're not able to get enough collected, you can always, patients are staying in remission for very long periods of time these days. You can revisit that process down the road as you've had further time removed off Darzalex.
what's enough?
Like 2 million.
What's enough for a transplant? Yeah, so it depends on who you talk to, but 2 to 3 million per transplant's typically what we'll use.
And there are medications to tell your bone marrow to make more cells to capture it from the blood, like Plerixafor is one that we use, and just the growth factor shots too. So we can get those out, but we target about trying to get 5 million at our institution so that you can have a couple for this transplant and some for later if you need it.
Okay, thank you. That's very helpful.
Okay.
And my second question is related to the pain. And my myeloma was caught very late, and I've had a lot of damage to my bones.
Okay.
How long before I'm not in constant pain? It's been 1.5 years. I just want to know when I'm not going to be in pain anymore.
So, I think, and this is your struggles are shared by, I'm sure, many people in this room, and, I hear this from my patients day in and day out. It's a very long process for those that have had significant bone damage at initial diagnosis. We can treat your disease into complete remission, but at the end of the day, there's been significant structural damage done to your spine, or other bones in your body. And that can take many, many months, to improve. But I have patients that are 1 year out, 2 years out from therapy, and as the disease remains in remission and it continued healing, and remodeling of bone, it just slowly gets better over time. There are some patients who do have some level of chronic pain related to their bone disease, even when they're treated into complete remission.
Right.
I'm not saying that that's going to be the case for you, but that can occur. But you're still early in the game, and especially if your pain's better now than it was at initial diagnosis, you can expect continued improvement in the months ahead.
Right. And depending on the problems, if it's due to a collapsed vertebra, we can do kyphoplasty to try to recover the height of the vertebra, and sometimes that can be very helpful to improve the pain. It just depends on what is causing the pain, and it's always important to remember that there are other causes for pain. So people who have myeloma can also have, lumbar problems. They can have all kinds of other things that are causing pain. And so it's good to see a neurologist or an orthopedist or someone who can assess what's going on and make sure what is causing the problem.
Right, and I agree, and we talked very briefly about pain yesterday, but we have pain colleagues that I work with real closely. Medications that are classified as antidepressants, there's one called Cymbalta, can be very effective in some people. And then the same medicines like that we use for neuropathy, the gabapentin to disrupt those pain signals in your brain. Also physical therapy to strengthen the muscles that support the spine and the joints. All those things can work real well, but talk to your providers. If they don't know you're in pain, then we'd have to have that discussion about strategies to help.
But in the big picture, I just want to emphasize one of the things that I started with today is that this is one of the big incentives to start the treatment earlier before issues emerge and can cause problems. I mean, I remember not so many years ago when we have these meetings, you know, we had to open the doors wide because so many people were coming in here in wheelchairs. You know, they had all kinds of issues. We don't see that anymore. And when couples come in, we don't know which one is the patient, you know, because they both look great, you know. In the past, that was not true. You know, it was very obvious who the patient was. And so, I mean, for the future, I think we're going to hopefully, you know, be preventing this kind of situation where it can be difficult to manage.
Yeah.
All right.
Over to one again?
Yeah. Name, please.
My name is Gerrit Walters. I live in Deerfield Beach. I lived in Holland from 65 on until the late 70s. And when I was in Netherlands there in the late 50s and the early 60s, thalidomide had formed misformed children, babies and fetuses by the thousands, if I'm not mistaken, 40,000. And now it is a medicine for multimyeloma. What does it do to our bodies if it creates misformed fetuses?
Yeah. The thalidomide.
Yeah. So this is a great question. So the story of thalidomide and the immunomodulatory drugs is really quite fascinating. So, you know, thalidomide unfortunately caused terrible birth defects. And the way in which it caused these horrible birth defects is by stunting the growth of blood vessels. You know, so as the fetus is growing arms and growing legs, the blood supply has to feed that, right? But the blood vessels were not growing appropriately. And in the 1980s, there's a strong interest in angiogenic therapies for cancer. So if you could choke off the blood supply to cancer, you know, you could control it. So thalidomide was taken off the shelf and it was applied in a number of different cancer types in various clinical trials. And in multiple myeloma, it worked, and it worked very well. And it wasn't only until, I think it was maybe 2015, 2016, something like that, where a very clever group of investigators in Japan determined how thalidomide works, how it causes birth defects. It binds to this protein inside of cells called cereblon, and it changes the proteins that are directed to the proteasome, the toilet that I was talking about, for degradation. And as it turns out, so that explains, so the biology is explained, but in the myeloma cell, you know, the thalidomide, the Revlimid, the Pomalyst comes in and binds to cereblon, and then it targets these important proteins called Ikaros and Aiolos for destruction. And these transcription factor proteins are very important for myeloma survival, and that's why they don't like Revlimid, thalidomide, and Pomalyst. So now that we know the target, so we've been using it for years, and we didn't exactly know how it worked. Now that we have the target, we can develop better drugs that target cereblon even better, and that's what these cell mods are. So iberdomide and mezigdomide are actually better at binding to the cereblon protein and targeting Ikaros and Aiolos in the myeloma cell for degradation. All of these drugs are with risk, right? You know, thalidomide had the unfortunate history behind it, but there's a lot of chemotherapeutics that if you applied to a pregnant woman would cause horrible fetal harm. So, I mean, we've got decades of experience with these now, right, in patients with multiple myeloma, and I think we've got a good handle on, you know, what the short-term and the long-term risks are associated with these drugs.
Yeah, they are remarkably safe. I think that the over time there's a question of whether you would have maybe a risk of getting some other kind of cancer, but that risk is really rather low. Even taking Revlimid for 5 years, 10 years, very long periods of time, that risk is not so elevated. One of the most interesting things about these IMiDs is that, we'd been studying myeloma cells for years, and all different factors can impact myeloma cell growth. And people were looking at this drug and that drug to see if it would be good in treatment. And then suddenly, completely out of left field, this drug, thalidomide, which is being studied as a sedative, produces dramatic benefit in myeloma and draws attention to this pathway, which has been delineated carefully here more recently. And so this was a pathway which had never been thought of as being important in the past. And so this is what you call serendipity.
Yeah, absolutely. And so kind of extending on that, there's a whole new area of cancer therapeutics where they're basically taking proteins that previously were thought to be undruggable, and they're developing drugs that will direct these proteins to destruction through the proteasome. So you're going to see this whole new field of cancer therapeutics unfold as a result of this serendipity.
Yeah, it's actually really amazing that we have these old drugs and finding these new druggable pathways, and that cereblon that the doctors talked about, we're studying that now in newly diagnosed myeloma patients that can't get transplants. And so we're moving these drugs up. So instead of that Revlimid up front or thalidomide up front in the studies Dr. Voorhees had mentioned, you or somebody in your support group might have access to one of these new trials. So especially if you're smoldering or MGUS, just keep getting monitored so we can get you treatment earlier with these new drugs.
Right. And the serendipity with thalidomide, it could easily have been missed. So Dr. Barloghi, he got the thalidomide from the gentleman in Boston who was studying angiogenesis. Volkman.
Yeah.
And he gave it to this first patient who he was interested to give it to, and it didn't work. It didn't work. So the decision was, well, he got all this thalidomide. Oh, well, we might as well give it to this patient in the room next door.
We wouldn't do that now.
And so they gave it to the patient in the room next door, who had a dramatic response. And so, these little details are just so interesting and ultimately very important.
Yes, very interesting.
Almost 24 years. I had Dr. Barloghi. I had a transplant.
Yeah. It's great to see you again live at the meeting here, okay?
24 years, and Dr. Barloghi started transplant setup before I came out of smoldering.
Mm-hmm.
But because of insurance, they wouldn't let me have it there. And I had to have it somewhere else, but they still followed the protocol. And I did not go through the tandem. I just did the one. And then because it was so far back long ago, I went 18 years with no medicine. My miracle medicine right now is Darzalex and Velcade. I am down to 0.5.
Wow.
All right.
My IgG is normal.
All right.
And Dr. Hoffman is my doctor.
All right.
Very good.
Very, very good. So
One more thing. Tomorrow night on Call the Midwife
yeah.
on PBS, they are starting it off with multiple myeloma. This is back in the early 60s, and they talk about it.
Mm-hmm.
Wow.
Yeah. So one comment I'll make related to this, which I think is so important, and I know there are a number of people in the room where this applies, is that we're very much focused on wiping out the myeloma to get this MRD undetected 0 at 10 to the minus 6. We're looking at 10 to the minus 8. Drive this all the way down. However, we've looked at this a few times, and actually, Dr. Hartmut Goldschmidt at the University of Heidelberg, he has patients where he studied them at 10 years, 20 years, some of them all the way out to 30 years. And so he had samples where we could study these long survivors and see if they were MRD negative or not. And the crazy thing is that about half the patients who were the longest survivors were not MRD negative. They had a little bit of myeloma left. And I think that we're paying much, much more attention now to how is the immune system regulating these little bits of myeloma so that you can stay in remission for many years. And so we can decide that we don't want to expose you to potentially toxic treatment, that we can allow you to live with your myeloma, and maybe there's some things we can do to enhance the immune system to continue to keep it in check.
Yeah, and just a quick point about the Darzalex, for those of you that are on it or don't know, it's loosely expressed, it targets the CD38, which sits on the cell of the myeloma, but anyhow, when you're testing a serum protein electrophoresis, that sometimes gets detected, so much of that 0.5 that's in her blood might be partly measuring the Darzalex and might partly measuring the myeloma, so discuss your labs and individual labs with your healthcare team. You might actually be zero if we could wash that Darzalex out of your blood. But that's just a side point.
Yeah, that's a good point. As we move in, we haven't really talked about it much, mass spectrometry. This is going to be for next year's seminar, I think.
Can't wait.
But when we're using very, very sensitive testing for IgG with mass spectrometry, you can tell the difference between the myeloma and the Darzalex.
Mm-hmm.
Yeah.
Yes.
Yeah. Anyway, okay.
Number 4 in the middle, Carol.
Okay, Carol Friedland from Boynton Beach. I was diagnosed in 2016, Kappa, light chain, but no M spike. So I went through RVD, then a stem cell, then RVD again,
Could you, yes.
RVD again, and then Pomalyst and Darzalex, which I'm on right now, but I'm
Okay.
relapsing very slowly. They told me the next drug will be Carpolis and Cytoxin.
Okay.
So I hadn't heard about Cytoxin, and I found out that it's going back to chemo again. So I'm a little,
Yeah.
What do you think?
Okay, yeah, go ahead, yeah.
So, you're kind of following, a very traditional pathway, and, the therapies that you're mentioning are very appropriate therapies. So, you got Darzalex, Pomalyst, and dexamethasone as your kind of second-line therapy, it sounds like, and it's starting to creep its way back up. So, Kyprolis is a proteasome inhibitor, which is very active in relapsed multiple myeloma patients. So a Kyprolis-based strategy is a very appropriate treatment option for you. Cyclophosphamide or Cytoxin is one of the agents that we will, combine with Kyprolis in certain circumstances. I think once we get beyond 2 lines of therapy, if you haven't considered clinical trials up to that point, it's very much worthwhile considering clinical trials at that point, because the best partner for Kyprolis, so for someone whose disease has developed resistance to both Darzalex and Pomalyst, the best partner for Kyprolis is a little less clear. The other thing I'll point out, and we'll hear more about this later today, the KarMMa-3 trial, which was a study that was looking at Abecma, which is, or Ida-cel, which is one of the 2 FDA-approved CAR T-cell products, versus investigator's choice, best standard of care. And that study was a positive trial, so patients who got Abecma stayed in remission longer than those who got kind of the traditional myeloma drugs. That was just recently published in the New England Journal of Medicine, and regulatory authorities, as we speak, are looking at those data sets, looking at the safety, looking at the efficacy to determine whether we can get a regulatory of approval of a BECMA earlier in the course of therapy. And if it holds true, you may actually have access to a BECMA as your third-line therapy in the not-too-distant future.
Yeah, so that would be obviously very helpful. And hopefully, as we've talked about, it's going to be more accessible as well, so it would be approved and available.
Yes, for sure. And so if we have the University of Miami and the Cleveland Clinic, Weston, and so those places do have clinical trials. I would look into what they have. Not anymore.
So you make your myeloma is making an antibody. It's making Kappa-Light chain antibody, and for most clinical trials, I mean, if you get a BECMA, that's FDA approved, it doesn't matter what your Kappa-Light chain level is when you go into treatment. On a clinical trial, it typically has to be 100 milligrams per liter or 10 milligrams per deciliter or higher in order to be on the study, because it has to be measurable.
Right.
And depending on how they count your therapies, you have the RVD and transplant and some more RVD, and that you might qualify for 4 prior lines of therapy, so you might fit the definition now of a candidate for BECMA, depending on where you go and who you see.
Just a comment that we are working to make clinical trials more real-world sensitive, where we need to have trials where they're available in a real-world situation where patients where it may be a little bit tougher to have traditional response criteria, that we do open it up to include and assess the response as best we can.
Yes.
Okay.
So I think we have one more question from
One
number...
last question, yeah.
Is it 2? Yes, Narmeen?
That's fine.
Yep.
Hi, I'm John from Orlando, and we're in the Maitland Fellowship Group. And my question is, a lot of the drugs that we take produce some collateral damage. How often do you recommend having echocardiograms?
So I guess it depends on what medication you're taking. So one of the drugs, this Kyprolis or carfilzomib, might be the one that you're referencing. And so it depends on what your baseline heart function is and what your risk factors are. And we have blood tests that we can measure the stress around your heart. There's one called an NT-proBNP. So if you have amyloidosis, that's a different discussion. So it really depends. We have some guidelines that say you don't even have to check echocardiograms, but it depends on if you have any symptoms and other health conditions.
If you're going to have a heart-related complication of Kyprolis-based therapy, it typically happens within the first 4 cycles or so. So if you've been on Kyprolis for an extended period of time, the likelihood that it's going to cause heart damage is very low, actually.
Right.
It declares itself pretty early in the course of the treatment.
And it is manifest as kind of more of an acute situation where, it's clear that related to the infusion that something's happening. The pressure changes, pulmonary hypertension, something is observable, and maybe even stop the infusion.
Yeah, but repeat echocardiograms would be dictated by symptoms. If someone is experiencing increasing shortness of breath, palpitations, other red flags that something's not quite right, that would trigger us to take a really close look at the heart.
Yeah, and if you've had long-standing high blood pressure or previous heart disease, but this might be the right drug for you, you should be followed by a cardiologist as well. So, tough question.
Right, and so my experience is that if you do have any even slight indicators of changes in blood pressure, systemic or pulmonary hypertension or tachycardia, I have a very low threshold. I don't want to be giving more.
Right. And that's the other thing is there's so many different doses of that Kyprolis, once a week, twice a week, and some people that get shortness of breath and don't tolerate it do better actually twice a week at a lower dose. So again, share your symptoms with your prescribing team and they'll individualize your care.
So thank you for your questions. Thanks to the panel for guiding through the answers here. Thanks to Peter for an excellent overview of initial therapies, and we will exit right